Shall we
I
go to
think
the
we
next?
can, yeah, we can ask Ramesh to chair the next session. Ramesh?
Yeah, I will chair it. Yeah. Who is speaking?
Yeah, TD will be.
Yeah, I will chair it. Yeah.
So maybe you can
TD Yadav, you
introduce.
are good to go. Everybody knows who is TD Yadav.
No, but
Professor of
still, because
Surgical.
we have a lot of or some participants from
Yeah,
abroad,
so
please
so
introduce him.
so TD Yadav is Professor of Surgical Gastroenterology at the Postgraduate Institute of Medical Education and Research at Chandigarh, one of India's most prestigious medical colleges and postgraduate teaching institutes. And he has done a lot of work on pancreatitis and on Whipples. And so I request him to take up his topic and manage it. Okay, he can start. No,
Yes,
not
yes.
wait for me.
Yes, sir. Yeah, TD,
So,
please.
good evening and thanks, sir, for giving this opportunity. Sorry, I got little bit late. Today was war and I got stuck up. So, this is a very specific topic, sir mentioned lots of discussion on acute pancreatitis and diagnosis and of infection, and only two things I have to discuss, and how to assess the severity. So I wrote a scoring system because different scoring systems are available. Not going into lots of detail of all the literature. Based on the PG students, they are sir said only PG level PG students they should understand. So I will show some good pictures of the city, and based on which we are managing our patients. So it is very, very important to just to start that I want to emphasize that it's very important to have a uh, good CT scan and lots of knowledge of presentation of the acute pancreatitis, as well as we should have clinical features of the this acute severe pancreatitis is very, very important. Even if we are having
TD आपका म्यूट हो गया हाँ unmute.
sorry, sir. There is a some outside the house, some limping is going on.
Yeah, now we can hear you. Please carry on.
There is just some sound going on the road. I don't know what is that. So that's why I have made very simple presentation. How we diagnose this patient and what we do. Infection diagnosis is very, very important. And there are only one differential which is important in a setting of acute severe pancreatitis early. That one is some ischemic bowel with some fluid collection, and another is there may be some sort of like perforation where there is no gas under the diaphragm, and you have not done CT scan. Then sometimes there can be a differential. So it is very, very important to understand these two important features we are finding in the routine. So to how we diagnose the infection in acute severe pancreatitis. So in the beginning, it's very important to look into the clinical features. So as I just listened very small part of the earlier presentation, and very nicely it was described that early and delayed late presentations, two phases of acute severe pancreatitis. So early phase usually it is because of the inflammatory mediators, and there is no setting of infection. That's why lots of controversy about the starting of antibiotics in an early phase of pancreatitis. So clinical features are very, very important. And if, meaning thereby we should see everything, including heart rate, pulse rate, heart rate, respiratory rate, and abdominal condition of the abdomen, then blood pressure, then what is the fever. If there is a fever, then we have to look into not only pancreas, other important structures also, which are there is a systemic presentation of the acute severe pancreatitis. Then what can be done earlier when we started managing pancreatitis, and it was said that sterile pancreatic necrosis usually doesn't need any treatment. So if patient deteriorates or develops fever, then you used to aspirate, put a needle under the guidance of CT or under the guidance of ultrasound. If it is available, if it can be managed, then aspirate the fluid and send it for culture. And if there is a growth of the bacteria or even gram staining and something is coming, then you used to start antibiotics, and antibiotics also based on this thing. Otherwise, you were not starting antibiotics. So that is one way that you can aspirate what is there. If there is no fluid, then even pancreatic necrosis area can be aspirated little bit. Second, now which is most commonly we are being done is you are going for a step-up approach, and if patient clinical situation demands, it is very, very important. Then one can have a percutaneous drainage when you put the tube, and at that time only aspirate the fluid and send it for culture. And if there is a growth of the bacteria, then it comes to we say that there is a infection. Third, very important is without having this any of intervention, if we have a patient where there is a gas in the pancreas, then it is very, very relevant, very important to know that it can be either by the gas forming bacteria, or it could be by the colonic fistula or even duodenal fistula, which is both these are more common. It can be even stomach, but gastric fistulae spontaneous is very, very rare. So if you are seeing in the bed, just I will show one picture of this thing. So this is the picture where you could see that the whole pancreas is full of gas, and there was no colonic fistula. So I'm not discussing about intervention or doing or not. I'm just only want to say that if this is available, then you can say that there is infection. If you aspirate fluid from the infected area, like in necrosis, and you are getting fluid like this, then again you can say that this particular pancreatitis is infected. Or if you are putting a PCD and you are still getting getting this thing getting this fluid and aspiration, and then you are going for a culture and sensitivity, and you are finding that there is a infection. So these are the three very important ways we can document that there is an infection. So whatever necrotizing pancreatitis is there, what we call one, whatever we call, it is now infected. So there is no I think other way by which we can diagnose. So what is the role of imaging? As I said, just I will take little bit just to show the CT scan, because CT is the gold standard for in the management of acute severe pancreatitis. And as I said, in the excellent image for the pancreas, can assess the pancreatic necrosis. We can see the extent of the necrosis. Why I am telling this? Because in our severity assessment, it is going to come. So it can sometimes identify cholelithiasis or other causes of abdominal pain, which might be complication or which might be sometimes unrelated, and identifying the complications like acute fluid collections, pseudocyst, which is going to be formed later on, or one or any vascular complication which can happen in acute severe pancreatitis, like pseudoaneurysm, which is common, which might bleed, which might not bleed, but if we are finding it, we have to go to manage it. So this is the CT scan. So we, based on the CT scan, we take one component is CT scan, by which we can say that this particular patient have a severe pancreatitis or it is not the severe pancreatitis. But CT is not the only thing. So I will go into part 2, which is these are some pictures. Part 2 is assessment of the severity. So we do CT scan very frequently. We sometimes repeat after 7 days. If in the progression time, as discussed earlier also, that usually 72 hours is the time when CT scan is indicated, until unless you are having some differential diagnosis problem or you are suspecting some complications of the acute severe pancreatitis, then only early CT scan might be required. Otherwise, in the beginning, only supportive care. So coming directly to the part 2 of my my talk, and that is severity assessment. So starting with we know that Ranson criteria, we know that Ranson had two components. One is for the stone disease, it is different little bit, and for the alcohol, it is little bit different. And it has 11 variables in it. And at the admission and after 48 hours, again you assess. But lots of drawbacks has been discussed about Ranson, because most of the patient, when they come to the hospital like tertiary care center, already that 48 hours is gone. So usually they present late. But it has been found that if your patient is of more than 55 age group, If there is obesity, which is very strong this thing, because the Apache score is also Apache O has been described in the literature to see the severity in a obese patient. So when there is organ failure at the admission and it is persisting, so suppose there is organ failure also had somebody discussed little bit. Organ failure has also two components. One is that how many organs are failing at the admission. Number of the failing organs at the admission, 20% increase in the mortality. Suppose there is one organ failing other than pancreas, 20%. If there is a respiratory failure, 20% add it at the admission we are talking about. And if it is persisting, then it is more significant. If it is reversed within 48 hours, after resuscitation, it means pancreatitis is going to be moderately severe. It might not be severe pancreatitis, might not need, as Dr. Sastry was talking about, might not need admission in the ICU. Then, if there is a pleural effusion, as I was discussing, at the admission, this is a significant marker of the patient is going to have a severe pancreatitis in the later on, and we have to be more careful. We can admit him in the high dependency unit. We have to monitor each and every organ and give supportive care so that patient doesn't deteriorate, and be ready to get admitted in the ICU or very high dependency unit. If hematocrit, again very important, is more than 44, again it is a very important predictor of the severity, which is at the admission, then patient is going to have a severe pancreatitis. So starting with the most simple and very important predictors of the severity, to bicep score, which has come later than after Ranson. And Ranson, as all we know, that Ranson score was very popular, but then Apache came. It came for the ICU. Then it has almost replaced the Ranson because of it can be bedside assessment. It can be assessed daily. So bedside assessment, bedside index of the severity, bicep score is very popular. It is very simple, and multiple this publication are there comparing its relevance with other scores like Ranson and other Apache, and it has been found that it is equally good. It can be managed bedside. Anyone can do it. So it has these 5 components: blood urea nitrogen more than 25 milligram per deciliter, impaired mental status, systemic inflammatory response syndrome that it was being discussed, if age is more than 60 years, and presence of pleural effusion. This is very, very important. If it is present, and then there is a scoring system based on the presence or absence of these variables. So what suggests a severe episode in the initial days, other than bicep score? So if you are doing, we all do CRP monitoring nowadays, and if his CRP at 48 hours is more than 150, it means this pancreatitis is going to be severe. If Apache scoring system is more than 8 at the admission, and it is going increasing day by day, again it is an indicator pointed toward the severity. And third, very important, is when after your full resuscitation, the hematocrit is not going down at 24 hours. After, as I said, these patients are usually lots of fluid loss in the third space, so that the hematocrit is high. But when you are adequately resuscitated, you have monitored the central venous pressure, you have monitored the IVC, and you are finding that hematocrit is not going down. It means it is going to have a severe acute pancreatitis. So very, very simple points we have to remember, and we have to monitor the patient. So as I said, lots of the scores are there. So Atlanta classification is just to see the different nomenclature, and which has a bearing in the management and outcome of the patient. Based on that, Ranson is important, Apache is important, bicep important, radiologic, which is most commonly used and very, very objective, other than biochemical, and which we can see in front of our eyes. But again, radiology is adjunct. Just based on the radiology, no decision is taken about the monitoring. So clinical, again, I'm repeating, clinical feature and clinical stability and clinical deterioration and the admission. These are 3 very important components of the management of severe acute pancreatitis. But as I said, CT will guide you how to go about that. And based on the CT scan, there is a Balthazar criteria and Balthazar grading system, A, B, C, D, E. And after that grading, there is a scoring has come. So 1, 2, 3, 4 numbers has been given based on the CT scan, extent of the necrosis, and then it has been said that what score is going to have a severe pancreatitis. So this is very important, and I think other than all biochemical parameters, CT is one of the very important factors. So I don't think it's I have to read everything, but for the everybody knows these are grading is given everywhere. So when you are doing, though there is you have diagnosed acute pancreatitis based on the clinical presentation and criteria which has already been discussed most probably. Then if pancreas is normal on CT scan, then you can say that grade A. And if there is a focal or diffuse enlargement of the pancreas, and there is some irregularity and inhomogeneous in the contour, but there is no fluid collection, then it is a grade B. And if there is a pancreatic gland abnormality in grade B, as well as there is a peripancreatic little bit of inflammation, people say there is a mesentery is inflamed. So there are clear-cut features of the inflammation on CT scan. So I saw in one of the CT. So that is grade C. The moment there is a fluid collection, it becomes grade D. So if there is a single collection of the fluid, as it was shown in one of the pictures, then it is a grade C and grade C. And if there is a C plus 1, 2 or more than true fluid collection or gas in the pancreas and fluid adjacent to the pancreas, then it becomes grade E. And just to recapitulate what pictures I showed in the beginning, so you could see that these are the grade. You could see this is a peripancreatic inflammation I was discussing about, lots of inflammation and necrosis, and this is gas, and this is a single collection in the pancreas, and this is a contour is deformed here. Pancreas is enhancing here, but contour is deformed here in the head region, neck and head region, and there is a peripancreatic inflammation severe. So as the peripancreatic inflammation, however, there is no fluid collection, so it will be above the C. It is not going to be C or D. So this is very, very important to understand. So Balthazar criteria, that's why it is very, very routinely used. And later on, after this grading, they have gone to a scoring system. So grade A has been assigned a score 0, and grade B has been assigned a score 1, and there is a less than 30% of the pancreatic necrosis. So you have to combine both. The pancreatic necrosis, as I show in one of the pictures, where is no fluid collection, that is very less than 30% necrosis. So that becomes grade B. There is no fluid collection. If there is a grade C, then assigned score is 2, and pancreatic necrosis is about 30 to 50%, meaning thereby either neck or head, it is not more than 50%. And this is assigned score is 4. And grade D, assigned score is 3. Pancreatic necrosis is more than 50%, and it is gets the score 6. So this is the highest score is 6, and grade E is a assigned score is 4. So this is very, very important for us to understand. Pancreatic is more than 50% this thing. So this just for the academic purposes. This is another model this scoring system in the modified CTSI, which has been after this Balthazar scoring, CT severity scoring system. And here also almost same. There is nothing much difference. So the score is almost same. If you see pancreatic inflammation is normal, intrinsic pancreatitis abnormality without inflammatory changes in the peripancreatic area. So peripancreatic changes are also very important. And then pancreatic and peripancreatic fluid collections and peripancreatic fat necrosis. However, there is no pancreatic necrosis that come in pancreatic inflammation. So intrapancreatic necrosis, meaning thereby the pancreatic parenchyma is not necrosed. But if there is necrosis, then either it be none, less than 30%, more than 30%. So I usually said that more than 30% is very, very important.
TD, sorry to interpret, but I think we are going over the same thing again and again. So I think we can wind up as fast as possible because it's just a repetition of the
Oh, that's
various.
mortal score. I was just, it is almost repetition. So mine is finished because this was the last scoring system. So just to show the certain pictures that we can say that we can ask agent based on this, what is the CTSI of this?
What is the scoring system that you use in your department regularly?
We are only using Balthazar system because
Balthazar system.
we
Okay.
are not using. That's for the academic.
You are using Balthazar system.
Yeah.
Okay. So thank you for covering overall detail with very nice pictures. You have a wonderful collection of acute pancreatitis, as I can see.
Yeah,
So
just to say the agent that here is a gas, but a good CT scan is the most important thing for the to plan the management also. That's why I took up this picture for their benefit, that from where we have to go and how we plan our management.
So any questions from the audience, from the PGs in the box? I can't see the chat box. So
no, I will read them. Ramesh, I'll read them.
Yeah.
So one just to repeat a very important point which has been mentioned by both Dr. Rajen Desai and Dr. S.K. Mathur, that if there is any doubt, then an early CT scan, because bowel ischemia would be picked up only by that. And Dr. Arun Singh wants to know on IV fluid therapy in the first 72 hours to prevent necrosis.
Who's going to take that?
TD, can you take that?
Or shall I take that question? Can I take that answer?
Yes, Ramesh, please.
Yeah. So there has been a change in the way we look at the fluid management. Initially, it was, there were no guidelines. And then there were the guidelines that came, which said that the fluid should be given in a large amount so that you have to replace a large amount of fluid. And the calculation was made where 100 ml per kilogram was given within 24 hours. And to maintain a urine output of about 50 ml in an average size male of about 60 kilo, which means 1 ml per minute was this thing. But then in the last 5 years, there has been a significant change in the way the fluids are given, because people realize patients are given a large amount of fluids in the beginning, started developing abdominal compartment syndromes in the later part of their pancreatitis. This was directly related to the fluid that was given. So the fluids that were given in the beginning moved out, and then they moved into the peroneal cavity and other places, and they cause a lot of other problems. So today we tend to give fluids at a slightly lower rate, and what we tend to do is that we tend to lower the PCV by 5% in 24 hours. If you can achieve a lowering of PCV by 5% in 24 hours, which would mean that you produce about 50 ml of urine per hour with fluids, and you have to titrate this every 4 hours. So a patient has to be in a high dependency unit, has to have a nurse and a doctor who is preferably in our centers, they are looked after by postgraduates in gastroenterology who look after the patient and make sure that they receive adequate fluids but not over fluids, and that their PCV index comes down. And that is something that is very, very important.
So, Dr. Ramesh, just one line about intra-abdominal pressure, and we did one thesis also. It's not only that it becomes pressure becomes high, the urine output goes down.
Yeah, that's what. Those are all the sequelae of IAP, rising IAP.
And again, we have seen people putting some tube or trying to put the tube, and it is exactly bowel edema. It's not that fluid is in the abdomen. It is lots of bowel edema, and by any means, it's very difficult other than opening the abdomen. If it is causes ACS, abdominal compartment syndrome, then we have sometimes we have put a Bogota, open the abdomen, make a laparostomy, just to decrease the bowel this thing. And monitoring, I think we should put one line that you can monitor.
Yeah, it has to be a Foley's catheter connected to a pressure system, which will tell you the
Intra-abdominal
cystic pressure, which is a correlation of the abdominal pressure. But we found the Bogota bag that they invariably burst, they have infection there. So what we have started doing is that if we find it high, what we do is we do 2 relaxing incisions on the lateral walls of the abdomen, where we incise down to the sheath, rectus sheath, and leave the only the one layer of the abdominal wall intact. This itself will lower the intra-abdominal pressure significantly, because rather than opening the abdomen, this one you divide the sheath laterally on both sides, and it makes the sheath actually moves out, and you can get quite a good amount of intra-abdominal pressure reduction.
Yeah, so the answer to Dr. Arun Singh's question, as has been mentioned by Dr. Ramesh, that from aggressive fluid resuscitation, giving liters of fluid in the early period, we have moved on to the general goal-directed fluid therapy, which is followed in any critically ill patient to maintain an adequate urine output so that you don't increase the intra-abdominal pressure to the limit of causing abdominal compartment syndrome, which then interferes with various other organ functions. So TD, maybe you can stop sharing so that I can put up Ramesh's slides.
Dr. I'm the next speaker?
Yes. Dr. Shastri, okay. Any comment before we move on to Dr. Ramesh's presentation?
Yeah, I think the point is made about the fluid management and the change in the perspective now from very aggressive to goal-directed fluid therapy, which I think every resident should know. What are the goals to be achieved in fluid therapy in various situations? When there is loss, when there is no loss. And I think it will be too much for us to mention the goals at this moment. You are advised to go back to your books and read about goal-directed fluid therapy. The other point I wanted to make about is the infection. Now, infection is something which is the main crucial game changer in acute pancreatitis, and it is most difficult to recognize when clinical sepsis signs are not present. If you have a high temperature and tachycardia and then high leukocytosis with in the background of necrosis, there is nothing. It's very simple. But you have a patient who is already an antibiotic. Most of them are referred to you with an antibiotic already. And a patient has an unsettled abdomen. These are the situations where one would like to know when to start an empirical antibiotic. Now here, mention is not made, but I don't know how many of you use procalcitonin. There is an important study by Severity and the role of procalcitonin in deciding whether to give antibiotic, continue antibiotic, or discontinue antibiotic. I think it's a very important paper, and it's a very simple test. And it really helps in the, one is always hesitant to put a needle and introduce infection to prove infection. So short of that, we don't do that. But we definitely do a procalcitonin. It is more than
we also would do a procalcitonin. And yeah. I think most centers today, especially with critical care people looking after this, the procalcitonin has become very popular. So they use it routinely. Sometimes I think they use it a little too much, and sometimes, all this sort of pushes the cost of treatment enormously in a private setup. So it's a government setup, it doesn't matter, but in a private setup, you have to count every penny. And so I keep telling them, see, look, think of the patient not as a endless money bag, but that he has limited funds. And do those. So what we have to teach our PGs, and this is relevant not only in acute pancreatitis, it is relevant in every disease that we treat. Before you do an investigation, think back. If this investigation comes as positive, what is going to be my management? If it comes as negative, what is it going to be my management? If the management is not going to change whether it's positive or negative, then you should not be doing that investigation. With this, you will eliminate a lot of unnecessary investigations.
Correct. So obviously, we don't do procalcitonin in all the cases. You do it only when you have a strong suspicion of infection, but not overt. Say in such situations, and then when the patient is already on antibiotics, you want to stop the antibiotic. See, procalcitonin would be a good guide there.